She's a lecturer in the Department of Health Professions Education at the Faculty of Medicine and Health Sciences. She holds a PhD in Health Professions Education from Stellenbosch University, an MPhil in Disability Studies, and BSc Audiology from the University of Cape Town. Her interests are in the areas of social justice through education, socially just pedagogies, transformative learning, decoloniality, interprofessional education and collaborative practice, as well as child health and disability studies. Her PhD research topic focused on the undergraduate medical students' experiences of social responsiveness in the curriculum. Anthea, we're looking forward to your presentation. And then, as Sim already said, colleagues, please add your questions in the chat throughout, and we will then present the questions to Anthea.
Thank you, Charmaine, and thank you so much, Sim. Thank you, colleagues, for joining me today in presenting this presentation. Charmaine and Sim, can you confirm if you can see my slides and if you see the proper full view and not the presenter's view?
Yes, I can see that.
Okay, great. Thank you so much. I'd like to just, take the opportunity again to say thank you for inviting me to present my PhD study in this forum and all the efforts that you made. And what I'm going to talk to today is about socially responsive curricula in medical education, a student perspective. I am very passionate about this, so I could talk in detail about a lot of this. So I really invite further conversations around this after the Auxin session. So yes, I would like to first acknowledge and thank my supervisors, Professor Cecilia Jacobs and Professor Susan van Schalkwyk, my participants. I also received funding from the National Research Foundation and the New Generation of Academics program, and also, of course, to thank my family and my mentor, Professor Liesel Frick, because none of this could be done without, it takes a village to raise a PhD as well. So if we look a little bit at the literature, my study is framed within a social justice agenda. So what I intended to do for today's presentation is to really just take you through what I found through my PhD. And if we start with looking at the literature, and we start with the higher education landscape, there has been shifts in the higher education landscape. There's been a call to really re-examine what the purpose of higher education is, to look and focus on what it is that we want our students to become, not only what we want them to know, and to really think critically about this. And are we preparing our students in a way that they can forge and create a better society? Within the healthcare context, globally, it's beset with substantial social inequalities that interact in complex ways with health and well-being. And so how do we prepare our students to deal with that complexity within the healthcare context? Within medical education, the seminal Lancet report in 2010 had already critiqued medical education as being fragmented, static, and outdated, the curricula, and that it's not preparing our graduates to respond to the complexities within the healthcare system. So there's been a large call to reconceptualize what medical education and health professions education looks like, and how we prepare our students to be able to respond to the healthcare needs in society. And so the curriculum is but one opportunity for us to engage in this preparation of our students. How do we transform the curricula and re-look at the norms of our curricula and our pedagogical practices so that we can build curricula that's socially responsive and capacitate our students to respond to the challenges that they face in society. So within the context of health professions education, social responsiveness is defined as an engagement in the course of actions responding to social needs. It's found on it's plotted along a social obligation scale, which is a continuum with social accountability on one end, social responsibility on the other, and social responsiveness in the middle. So for the purposes of this study, we drew on this definition offered by Boulin and Woolard, recognizing that there are limitations to the definition, but we worked with that for now. So the premise of my study, a fundamental premise, is that students are key role players in curriculum and are co-constructors of their learning. And so having said that, we recognize that students have a unique perspective of the curriculum in action, and that we really need to see how we can bring them into reconceptualizing medical education, because currently the literature finds that students are largely seen as consumers of the curriculum. Students are also positioned as, the educators are positioned as the sole experts. So student involvement in curricular change has often been tokenistic or intermittent and very peripheral. And how do we really bring them in to be co-constructors of their learning? And so if we are going to be working towards educating future healthcare professionals who are not only clinically competent, but who are socially responsive, having the necessary critical consciousness of health inequality, and focusing on issues of inequity and social justice, how do we partner with students to do this? But to do that, we need to first understand what is students' perspectives of social responsiveness, and what is their experience of that within the curriculum. And so to do that, I framed my PhD within using the conceptual frameworks of socially just pedagogies as well as transformative learning, where social just pedagogies seek to empower and foster agency within students and educators to be able to transform society. Transformative learning seeks to challenge the assumptions, beliefs, and problematic frames of references. So I used both of these larger frameworks as a lens to look at my study. So my study, the broader research question was how, if at all, has the MBCHB curriculum influenced undergraduate medical students to become socially responsive? And then there were three additional questions that were looking at: what do students understand of the concepts of social responsiveness? How do they experience social responsiveness in the teaching, learning, in their clinical engagement? And how do they then apply their understanding to how they deliver healthcare as students? I must note that my study was conducted on students that are part of the outgoing MBCHB curriculum, and that a lot of change is already taking place in the MBCHB curriculum. And so I hope that these findings can further inform the ongoing development of the renewed curriculum. So I adopted an exploratory case study, and my study was positioned with an interpretive paradigm. I engaged with 27 final year medical students across both the urban and rural remote clinical placements. I used a variety of data collection methods. We used focus groups. We then also had students draw rich picture drawings, individual rich picture drawings, and then I had one-on-one in-depth interviews with the students to explore what they captured in their drawings, and then we had follow-up focus group discussions. My data was analyzed using reflexive thematic analysis. And so there was a range of findings that came through, and from the student perspective, and what came through in the data was that becoming socially responsive is a complex and multifaceted process. So although I will report on these findings individually and these themes, they actually interact in complex ways. There's an interplay between them, and there's an interplay in how it plays out at the level of the curriculum, at the level of the individual system, at the individual student, and at the level of the health system. And so they interact in a multidirectional manner. And these dimensions, student, curriculum, healthcare system, play out in all of the themes. So the themes were the cultures and traditions of medicine, shattering of mindsets, the value of the student voice in the curriculum, applying a socially responsive approach to healthcare. And as I share the findings, what I will do is I will draw on some of the rich pictures and share some of the quotations to support the themes.
Sorry, I'm supposed to say
System, I'm wondering if we can mute the person that came.
Yes.
Great.
Sorry
Thank
about
you.
that.
No problem. So if we look at the first theme, the culture and traditions of medicine, students acknowledge the attempts in the MBCHB curriculum to shift the way things are traditionally done. They acknowledged that there's certain content, that there's certain teaching and learning activities, and certain clinical placements that help create awareness of the injustices and the inequalities in the healthcare system. So examples related to primary healthcare settings being very helpful, modules like Drucker, the integrated distributed engagement to advanced learning, the ideal module. These were very helpful and helped them to sensitize them to issues of discrimination, social determinants of health, as well as help them develop advocacy skills that were necessary. However, there was concerns around the frequency, the timing, and the value that was placed on these types of engagement in response to engagement and teaching related to the biomedical focus. And so students still felt that their curriculum was largely one-dimensional, with the dimension being the biomedical dimension. And so this student drew a magnifying glass and indicated that I drew a magnifying glass looking at disease, because what often happens is that in the curriculum, there was a perspective that it was largely disease focused, and that you start to then forget about the patients, the actual people, and you start looking at the disease and not the person as a whole. And so this also at the level of the health system and the pressure of the burden of care in the health system and the amount of people coming through the health system, students had to just work at a disease level, and they couldn't spend time to focus on other aspects that complemented and provided a more holistic approach to care. Students also felt that, how are we going to shift this? They felt that it might be challenging to shift this because the culture and tradition of medicine, the discipline, as well as medical education, was largely hierarchical and was largely based in this biomedical orientation. And that they felt that many people that they engage with were quite rigid in their ways, that this has always been the way that we did this, and that breaking these boundaries would be challenging, and that people don't really like to shake things up that have been there for a long while because there's a fear of what will happen. However, students still argued for the importance that we need to shift things. And so this leads us to the second theme, which is shattering of mindsets. This theme comes from the words of one of the students. So the shattering of mindsets is where students acknowledge that throughout their curriculum and throughout their 6-year journey of MBCHB, there was moments that challenged them to shift their perspective in profound ways, that it shattered their mindset, that it opened their eyes, that it was bursting their bubble. So in the image, you see a closed eye and an open eye, and the curriculum being, and the MBCHB experience being a bit of a journey between the realities of what's happening in the global world at the bottom, and then you'll see on top, on the left-hand corner, you'll see the different type of housing and social determinants of health, and that it was necessary to open your mind. But the student also spoke about an intentional or willful ignorance that some people might not want to or be ready to engage with this shattering of your mindset and your belief systems. Because it was easy to get trapped in your own little bubble, your bubble of doing things and experiencing and looking at the world from your own perspective. But it was necessary to challenge your assumptions, to be both internally aware of ourselves and aware of the circumstances and the perspectives that the patients and the system bring. And that awareness was also related to the socio-political nature of healthcare. And so this final thing that I want to share around this theme is that this participant drew these bubbles, and she reflected how these bubbles act as boundaries, and it was necessary to break these boundaries, break the boundaries of our mindsets, break the boundaries of how we communicate, breaking the difference between the socioeconomic difference, or breaking the language barrier, or breaking the pedestal that puts you at a different level to patients, and that this was essential to be able to be socially responsive. The third theme, the value of the student voice in the curriculum. Students felt that largely that they didn't have a voice, that they wanted to be involved, but their opinion didn't matter and it was not valued. And that even though it wasn't valued, they themselves recognized the value that they had to offer. And so one student said that they really want to change the interpersonal culture between themselves as students and their seniors, such that because they don't want to be feeling that they're at the bottom of the food chain, they want, because they're on the ground level, they are hearing new things. I'm hearing the complaints or the dissatisfaction or the new things or the innovative ideas that somebody a lot higher than me might not be able to hear. And I think that that might not be able to hear is quite an important element, because we need to ask ourselves, are we willing to listen and engage with students in a meaningful manner? And so this last piece of data related to this theme, I found it was very lovely that this participant, Lucas, he drew this picture of an ant, and the ant is holding up the health system. And he says, I don't know if you know much about ants, because he sees, this is his view of students, but ants are very, very small, and they can lift up more than 10 times their body mass. They can lift extreme loads, and even though they are so small, they are able to move these big loads and make a change. So that's how I view students, especially in this curriculum and the forthcoming curriculum. It doesn't matter how small you are, you can make a change. So even though they recognize that, or they felt that their voice wasn't valued and that there wasn't space for their voice, they still felt that they had value to offer, and that they were challenging the educators to include them. And then the final theme, applying a socially responsive approach to healthcare. So this theme looks at students, how they looked at their experiences, how they drew on what they understood to be social responsiveness, and recognized that as an individual, as a student, I bring my values into the space, and I bring who I am into the space. And so who I am as an individual student interacts with what's happening in the context, interacts with what I've been taught within the curriculum. And so the students really highlighted that there needs to be a contextualized approach to social responsive healthcare, as well as a personalized approach. But also they highlighted that there was tensions between what they wanted to do and the pressure and the challenges of the healthcare system. So this example, the student talks about, we cannot just look at the patient not taking their medication. They need to understand what is happening. So this awareness, it's not that the patient just doesn't want to take his medication. Maybe it's because their context doesn't allow them to take their medication. Maybe they're supposed to take their medication at night or with food, but they work a night job, so they can't take that medication. However, despite the challenges, they were saying that it is not acceptable to be able to not, for any healthcare professional to not take into account the context and to not deliver responsive care. So they recognize that it is often happening, that you can pitch up as a professional and just do the biomedical professional stuff and never really engage socially. And it will be acceptable, but it shouldn't be, especially not in our context of South Africa and not in our profession. And in order to shift that, there was a need to build a different way of being, to practice more self-reflexive behavior, to be more conscious. And the students saw this as an active process to consciously remind themselves and practice that behavior more often so that it becomes a new way of doing and being, a new habit. And then you don't have to think about it that much anymore. So I want us to really think carefully about the medical curriculum, think about medical education, and recognize that medical education and health profession education is not neutral. We need to pay close attention to how our curriculum is shaping who students are becoming. And who they are becoming is a matter of our choices, what we include, what we don't include. The sequencing and the timing of these choices are not made in a vacuum. As educators, we bring all of ourselves into that space, and that's influenced and shaped by the disciplinary cultures, tradition, and values. We need to recognize that if we want to prepare our students to respond to societal inequities and how they present within the healthcare domain, we have an opportunity for medical education and HPE to explicitly align with a social justice agenda, to dismantle systems and structures that continue to uphold health inequality. And so we really need to consider what we value as within our curriculum, and the value that we place on particular knowledge gives it power. And normally, powerful knowledge in the literature is considered to be disciplinary knowledge. And what we're arguing is that the disciplinary knowledge is important, but we need to shift beyond the biomedical knowledge, and we need to include knowledge that helps students grapple with these health inequalities and the social injustices. We need to include that as powerful knowledge. So that would mean that we need to reframe what counts as powerful knowledge in health professions education, and we need to expand epistemological access for the students to this. And as we do that, we need to really look at the role of the student in shifting the curriculum. So as we reimagine what role the student plays in this, we need to remember that the students bring unique perspectives and strengths, and that they are in many ways co-constructors of their learning. And to do that, we're going to have to challenge the power dynamics within health professions education and medical education. We need to shift from from considering students as consumers of the curriculum, and we really need to allow them to participate on an equal footing with educators in transforming the curriculum. That does not mean that the educator doesn't have power and doesn't bring expertise. Each one brings their own strength into that space. And so this requires courage, and it requires us to intentionally shift our natural way of doing, or the way we've been trained to do education. And so socially just pedagogies and critical pedagogies emphasize, as well as transformative learning, are means to allow us to reimagine the role of the student and do transformation of medical education in a different way. Socially just pedagogies emphasize the notion of participatory parity, where we value all that the student brings at the different levels, from their culture to their economic capital, their cultural capital, their political capital, and how we allow them into the processes. And so these socially just pedagogies, critical pedagogy, and transformative learning can be a vehicle to enable the necessary development of social responsiveness in medical education, as well as in the students. We recognize that the curriculum is also just a component of transformation, and that our students within medical education, their education plays out within a system and a context that is shaped by many multiple contributing factors, the socio-political nature, the disciplinary field, many other factors. And so the curriculum change has got to take place in a context that is willing to change as well. And so there needs to be engagement and change management processes on the level of the health system. It cannot just be at the curriculum. And so students and educators need to work together personally. They have to look inwardly and collectively to make sense of what social responsiveness is and the necessary action that they need to take to dismantle the systems and the structures that sustain social injustices in medical education and in healthcare. And so as a final concluding slide, I want us to consider the words of Ron Barnett. As we endeavor to partner with students as co-constructors, we need to think about the kinds of human beings that we want our students to become. And that is partly a matter of our value choices. This is a profoundly difficult task, and time, however, may not be on our side. So thank you. I am open to have any questions.
Thank you so much, Anthea. That was a wonderful presentation and really interesting to hear how insightful your student participants are. Really wonderful. I want to invite the colleagues to ask any questions. I can see in the chat Jean has commented on one of the drawings, really insightful. So that was really interesting as part of your methodology to use the rich drawings as well. And then Justine, I think it's Justine saying the context needs to be willing to change. Any advice for faculty development as our renewed curriculum rolls out into fourth year and ahead? So, Justine, I don't know if you want to elaborate on your question.
Yeah, hi. Thanks so much, Anthea. I love listening to you speak every time. And when I hear you, I think of so many people who need to hear what you have to say. And we're becoming more and more concerned as the students are heading next year into the hospital setting, that the faculty there are not prepared for the students coming. So I don't know whether you have any advice. And when you said the context needs to be willing to change, I thought, yeah, that's exactly it. You really hit the nail on the head there. Because yeah, it's just so interesting to watch the colleagues as we've been rolling out one semester after the next, that a lot of them will say, well, students actually come to the party. They say things. Sometimes it does feel like they are very self-centered and young, which they are, and very demanding of the lecturers who are in such a difficult position, being consultants or working in hospital and having to come and teach. But then you look at some of the feedback they're giving and they're saying what is expected of them is completely unrealistic. And they are pushing back and it's not being received very well. And I just I'm grappling with that in my head. How do we prepare our faculty better? Because, there's also the hierarchy in medicine, which is very strong. And so students who have a voice and students, we've, in a sense, creating students with agency, but they're not very welcomed. I don't know whether you came across anything like that in your studies.
So maybe what I didn't foreground at the beginning, Justine, thank you. It's a really important point, is that my study was connected to a broader study. And the biggest study looked at across 6 institutions in South Africa, looking at how educators understood the principles that underpin their curricula and how they enacted that within their teaching and learning approaches. And what came through in that study is that many people were not sure. There was a range of understandings, but also they were not sure who should be responsible for doing this change in the curriculum and within the context. And also there's a sense of, I don't know that I'm quite prepared. I'm still myself trying to make sense of what all of this means and how to make a change in the space that I'm in. And so I agree, faculty development is very important. And Susan and Julia wrote a lovely paper around that I'm happy to share with some ideas around that. But you know, we recognize that this journey, what came out of that bigger study was that this journey it's a journey, and that everyone is at different points on the journey, but and that there is not necessarily an end point, but the starting point is with self. And so as we engage with the people that are engaging with our students in the healthcare context, as we engage with the educators that feel that, look, this is not my responsibility, I don't know how to do this. And some feel that I can do this. And we need to look at how we build in the words of one of the other participants, was a coalition of the willing, and how that coalition of the willing will then support and champion this and help build scholarship, and I mean that in a broader sense of scholarship, and capacitate the other faculty to see that this is possible, and we can work together, and we can challenge our own beliefs and our own assumptions, and we can look at good examples of how it is done. And so faculty development is really important, and it'll play out as engaging at a philosophical level. What are these? What are the philosophies that underpin this? What does it mean for me? And then how do I practically do that? So from the broader study, they are still working on more practice-based publication, but I'm happy to share the other stuff that have come out.
Thank you very much. That's helpful. The other question I have, if I may tag it on there, is something that has been coming to the fore is the expectations of the students, even those in the renewed curriculum. They're comparing themselves to what has gone before. And whereas the cohort that you spoke to was saying we need to change and it needs to become what we're trying to now do, the students who are in this new boat are super critical of what's going on and very uncomfortable. And they, I think, are being influenced by what has gone before and maybe parental expectations and other expectations, and don't think this is such a fabulous idea at all. You know, all this transformation and so how does one respond to that?
I think, Justine, you are at the forefront of that. Yeah. I could really lean into your wisdom and the others that are championing the renewed curriculum. But I think that there is a tendency to look into another camp. The grass always seems a little bit greener on the other side. But seriously, it's about challenging those assumptions and trying to understand where those perceptions come from, that the others were better off, and that could also be rooted in the traditions and the cultures of what people have expected medical education should be like, and now they've got a completely different reality, and so then that doesn't sit comfortably with them. But I think, you know, I don't have a direct answer for that, Justine.
Thanks, Anthea. So we have a couple of hands up and also a comment from Jean. But I'm going to, I think, Marianne Unger, you had your hand up first if you want to switch on your mic.
My mic as well. Oh, hold on. I'm standing. There we go. Thanks. And I really appreciated Justine's comment. We have the same experience in physio with the students who are now participating in our renewed curriculum. And as fate would have it, we've just had a World Physiotherapy Africa Region Congress, and one of our first-year students had the privilege of attending that. His mother happens to be a physio. And towards the end of the Congress, when I bumped into him, he said, all the students should have been here because for the first time, they're really starting to understand the problems, particularly on the African context. And now he understands why we're doing what we're doing. And he's more than ever enthusiastic to spread the word of why we have so significantly changed how we approach our education practices with the new generation of healthcare students. So yeah, I mean, I don't know how we get all our students to world platforms such as these congresses, but yeah, it was an interesting phenomena that really assisted us in this particular case to get them to value why we cannot keep doing what we're doing and that it is time to do something significantly different. But thanks, wonderful study. Well done.
Thank you, Marianne. I wondered, though, that those students that came to that engagement had the opportunity to have a little bit of a rear view, a perspective of the evolution of where you were and why you are changing. And sometimes we change, but we don't necessarily contextualize the change for students so that they can understand what was before and what were the gaps and why things were changing. And I know a lot of effort has been made in these renewed curricula to help students understand, but they weren't part of what was before. And I think it's really important to do that type of contextualizing.
I think that also it links with Jean's comment. I don't know, Anthea, if you were able to see that, but just for the students to be part of your study, what a transformational experience it must have been for them. And at the end, I don't think many of us ever take the time to reflect as this exercise has done. So just this experience for the students, how valuable it was for them to also understand what it is that they might be working towards.
Yeah, no, I agree completely. Jean, thanks for the comment. And I actually, as part of my methodology, I asked the students, but in relation to the rich picture, how did you find this process of doing a rich picture drawing around this concept? And they shared how valuable it was for them because I gave them a period of 4 weeks to capture their drawing as they were doing their rotations, as they were doing life as a student, to just draw. Some drew throughout, some waited till the 2 days before it was due to draw, but they were capturing their thoughts, and they said that it really gave them insight, and they look at things differently now. So I agree, it was very valuable for them, and they were a wonderful bunch of students. Really, they showed up for all phases of data collection. I'm eternally grateful to them, and I learned so much from them. I see Lindsay's hand is up.
Yeah, and before that, Prof. Chapanduka also had his hand up.
Okay, sorry, I didn't see.
No, with apologies, I have my answer. Thanks.
Okay.
So I suppose I can go now. So thank you very much for a very insightful presentation. And for me, it is even more interesting at the back of attending the Central Karoo outreach that we had with Dr. Fish as well as Prof. Baikis. And it was around having our third year students cohort volunteer to attend. And I must say that for me, what you are sharing is what I experienced during this outreach, or inreach, as we call it, because it gave our third year students a platform in which to not only engage with students from UWC, but also Nelson Mandela University, but work transdisciplinary almost. I mean, you had third year medical students working with final year dentistry students from UWC. But it wasn't so much the action, it was the engagement and the interest that they've collectively showed in terms of the context in which they are working and working towards a common goal. And that in itself, based on the feedback that we had received anecdotally from our students, have been so enriching, because now relationships are being built. And so there's a greater understanding now for why they are doing medicine, for example, but also understanding the value of working in a collaborative team. And so thank you very much for providing almost the academic part of what I experienced during the Enrich. And I think that this is what we should encourage, this volunteerism amongst our students into communities and create opportunities for that. So thank you.
Thank you, Lindsay Michelle. I was in a session with Prof. Fish just before this, and she was sharing about, serve to learn and that experience, and the value of the reciprocity of learning that took place in that space. And I think that relating to social responsiveness, as students engage in a socially responsive way and try to shift and advance social justice through healthcare and health professions education, we really need to value that reciprocal nature of learning that takes place in the community, and not only through the interprofessional collaboration, but like collaborating in a true sense with the community members.
Correct. And also having our students engage with the patients while they were waiting and talking with them, learning about their stories, has also enriched their learning in terms of what it is that they can contribute. Because once we graduate our students, they are de facto leaders in communities, and they don't always understand that responsibility. So thank you very much for sharing your expertise, and maybe, who knows, in the future that we will have an in-reach as opposed to an outreach into various communities, and in particularly rural communities.
I like that, Lindsay. Thank you.
Thank you, Anthea. I see there's a few more comments. Justine said thank you to Lindsay. That makes her very happy. Corin Wolf, beautiful, insightful work. Anthea, thank you so much for sharing. I was wondering a question that maybe links to what Lindsay Michelle also asked you, just out of interest, and maybe you found something interesting around how did students experience it differently, the students that were placed in more urban clinical settings as opposed to the students in the rural clinical settings?
So I never analyzed my data to look at comparison, but from a non-analytical soft eyes analysis, and from listening to the students, definitely they perceived that the more remote and rural primary health type settings was very helpful for them to become socially responsive and for them to engage with the issues that are needed to shift their perspectives and change their thinking, and to want to become a different type of doctor. Whereas in the more tertiary type settings and more urban settings, the pressure and the volume of numbers, but then it was also not just settings, they also spoke to certain disciplines that were better. So family medicine, they found, was quite helpful in helping engage with these type of concepts. And then they speak to modules like Drucker, and Ideal takes them out into the rural areas. But emergency medicine, there wasn't space for that and the time. And so they spoke to those type of pressures, not only at the different rural and urban, but also within the different disciplines within a particular space. But also being in the rural space, they really felt that they were part of the team. And that also changed the way they learned, and how they engaged and how they show up in that space, because they were very actively involved in shifting and changing and making a difference.
Very interesting. Thank you so much. There's Lindsay Michelle shared an article about their InReach. And let me see if there's other comments. So not at the moment. Anyone wants to put up their hand that has another question for Anthea? I see in the blurb for the Auxin that you have already published an article with colleagues. So it would be interesting to go and read a little bit further on this. Really looking forward to reading it. And one of your supervisors, Susan, saying very proud of this excellent work. Well done, Anthea.
Thank you. Thank you, Susan. The publication is related to the broader study. The PhD publications are still underway.
Yeah, but it fits in there.
Yes.
I see Sim has a question for you.
Yes, thank you, Anthea, for the presentation. I quickly wanted to ask where to from here, because there's all of these insights that the students are bringing as their experiences, and I'm seeing this also forming part as student feedback. So what are the conversations that are taking part? And I'm sorry, I forgot now the earlier speaker who was commenting on the actual experiences that she is encountering on the floor, on the ground. So can you take us through that quickly?
So I think where to is to practically engage in some workshops with the people that are shifting the curriculum. So this is part of like dissemination, but also engaging in with those that are on the front line, if I can put it that way, and working together to find practical ways that they can implement it. So Lindsay Michelle shared the example of Central Karoo InReach, and that is a wonderful example, but that it doesn't happen as regularly as, and it's obviously a monumental task to coordinate that. So how do we bring this into maybe smaller, more bite-sized chunks, and involve the students in the process? So those are some of my beginning thoughts.
I was trying to think how to relate this to programs in other disciplines and other faculties. And I guess one of the first questions that might also come up is in curriculums that's already very full, moving away from content knowledge focus is very difficult for some to see how to do that. And I guess it's the same in your specific context, where we would say, but and as Justine also said, the parents are expecting their children to have specific knowledge around certain things, and now how do you go about starting those discussions around moving away from the content, the biomedical knowledge?
Jean, is your comment related to Charmaine?
Yes, Anthea, I'll give you a chance to respond, but I would like to extend an invitation which may contribute to a response to Charmaine.
Okay. So Charmaine, I think that it speaks to that reframing of what counts as powerful knowledge. And that's some real deep thinking and challenging what we value within that space, because we value content and we value the biomedical content, and we keep expanding the curriculum, and it should be valued. I'm not saying it shouldn't be valued, so I'm not saying negate that, but there needs to be a balance, and we need to shift that. And so it requires a willingness to disrupt and resist and push against, and even disrupt with kindness against these norms that we've decided that the curriculum should be like. And it's not going to be easy. I recognize that. And it can be uncomfortable for many, but it's necessary. And so in all these spaces where curriculum change is taking place, we really need voices that are pushing against the business as usual and this like curriculum expansion. We're just bringing more and more content on, but actually changing the way we do things and the values that underpin our curriculum and the choices that we make for our teaching and learning. And so we need to reframe that, and that will take time. It's not going to happen overnight. So sorry, Jean, do you want to add?
Yes, please, if I may. Thank you very much, Dr. Hansen. I'm really amazed at your work. And as someone also, I have to comment, someone with a linguistics background, the millennial use of the word like in so many of the references from the students that you've put up, I've picked up on the word like. Both my kids also use that word so often. So I suppose it's like our me who's nearly 60 years old. So, but yes, I agree with you that, you know, the change comes slowly. I do think that finding as many opportunities to get your work out there, because this is really, really transformational work. And just for context, I work at the Transformation Office. So I would like to extend an invitation to you to do a transformation learning network session with me. So I'll send you an email if you are open to that. And then, you know, to get the word out further than only health sciences. Not that we are only health science people in this room, but you know, as Charmaine says, how do we get the message out further? So slowly, but I think also for me to offer you an opportunity to get it out a little less slowly, and then to open other people's minds, I think, to how we can change and adapt the curriculum for students to become more sensitive to social justice issues. Congratulations on wonderful work, and to your promoter, Professor Susan van Schalkwyk as well. I'm really very impressed with your work, Dr. Hansen. So if you don't mind, I'll send you an email.
Thank you so much, Jean. I appreciate that. And we can connect offline around that. But I also want to say, like before we close, that there is a lot of good work that's taking place. And we're recognizing that shifts are underway, and that there's still a lot of work to do, but there is a lot that is taking place, and we must celebrate that. So yeah, so it would be good to. I'm glad that you've received this presentation well, but it will be really good to keep the conversation going. So thank you.
So with that, I'd just like to thank you, Anthea, for a wonderful presentation. Well done on the work that you did and that you are continuing to do in your faculty, and it will be wonderful to work with Jean to see how we can spread this to other faculties as well. So really well done on your work, and all the best for the future. Over to Sim.
Thank you so much.
Yes, no, colleagues, thank you so much. Thank you, Anthea, for such a thought-provoking presentation. So yes, colleagues, thank you to all the other members for joining in and supporting Anthea throughout the presentation and the feedback that you have given. So this was our last Center for Teaching and Learning Auxin conversation for the year. I would like to share a call to all of you to please forward me any ideas on teaching, learning and assessment projects that are happening at the university in your departments and faculties, so we can share those wonderful and interesting ideas that are happening in your environments. So yes, that was it. Thank you so much.
Thank you. Bye-bye.
Bye, everyone.